functioning, do some containment. So really she'll have a base and some sense of resiliency and resources to be able to get a new treatment. It is still too raw for her. So we will still then, as you can see, once we get her and transition her to specialty mental health treatment when she's ready, we will still continue to co-manage her. It's not like we're sending her off to, Never Land. We hired a primary care provider who would work in private practice for years, and he's like, I was used to, if I gave a referral for behavioral health, it was like a message in a bottle, never to be heard from again. We still have to collaborate, and once she's stabilized, and we have a trauma-focused CBT collaborative we're part of, once she's stabilized, I can then resume seeing her for monitoring in primary care. Because in primary care, people are coming. They're coming for issues. She will see the primary care provider probably every 4 months for diabetes management and for seizures, which frankly, of course, are made much, much worse by drinking. So we have her clean and sober now, but she's still wanting to work on some basic techniques for coping before we move into specialty mental health. But I can then see her for monitoring, so it is a fluid bi-directional system. We can't have a one-way system for specialty mental health. We don't have enough specialty mental health providers for it. We don't. If we send everybody who needs therapy to therapy, they're not. You can take all the therapists in the country, multiply them by 3, and we still wouldn't have enough, right? So we need to absorb people to mirror what we would do with a patient with diabetes. The primary care provider sees them, and if you are not able to control their glucose levels, what do? You refer to endocrinologist. Once that person has been able to manage that patient, do they see that patient forever and ever? No. They get reabsorbed in primary care. And that's exactly what we do with our patients. So that is, again, the bi-directional model of care that's very fluid. A critical part of this is communication. So this guy is lying on this couch. My physical therapist says it's the worst possible position you can lie in. We have to talk to each other. You have to do that. The way you communicate is critical. Face-to-face feedback is absolutely essential, that in that moment, here's what's happening, here's what I think needs to happen in terms of the treatment plan. I'm going to put it in the documentation. It's all shared. Everybody knows what the next step in this coordinated treatment plan is. We have treatment teams that range from, in each clinic, that range from 30 minutes to an hour, depending on the size of the clinic, where kind of high-utilizing patients or more challenging patients are discussed. And that is an important time to communicate and collaborate about patients. We do a lot of telehealth consultation, and also the electronic health record, which we had to battle big time to develop and make into an integrated record. Talk about trying to fit a square peg into a round hole, right? The health record was not designed to be a really fluid, easy, integrated health record for all of us. So we had to make that work. We redid all of them. Just telling you. Half of my white hairs, gray hairs is because of that. All right, integrated psychiatry into primary care. The goal. So I'm going to talk about this in particular because it's so neat for me. I sat down and I got to meet our 2 child psychiatrists who are integrating care. So I promised them I would give the example of our child psychiatrist. So we need to increase access to psychophoric expertise for our primary care populations. Those of you who have done family practice residencies or taught family practice residencies, how much psychiatry is taught? How much behavioral health is taught? It's like 7 minutes? 7 weeks? Before we change things, all the family practice internal medicine residents would do their psychiatry rotations with us, and we would always know when and where they went on vacation because that's when they took vacation. It's like, oh, you've got 4, but only 1 guy's coming for that 1 week, and that's when they all took vacation. And I don't know why, because they go out to the real world, and suddenly 80% of what they're doing is behavioral health. Most behavioral health prescriptions, what is it, like 80% are prescribed by primary care providers, but they don't necessarily have the training and knowledge. We cases of abuse and trauma, they will give us lists of psych meds. I don't even know how they're walking. I don't know how they're walking. They've come from some state or some place where before they lost their health insurance, I have had people who are just on 9, 10 psych meds, and they come to primary care and we're supposed to sort this out. How are we going to sort this out? It's not just a matter of first-line Prozac or Celexa or, Zoloft. It really is about, we need to decide what is going on here. And too much, there's a symptom chasing, right? Something for sleep, something to wake you up. It's the Elvis regimen, as we call it. Something to wake you up, something to make you go to sleep. Something for, weight gain, something for this. So we need to bring psychoform access to primary care. We need to increase the skills of primary care because talk about a workforce shortage, there are just not enough psychiatrists. They're just not there. Again, I'm waiting to talk to someone who can say, we have all the psychiatrists we need. We are overflowing with psychiatry. Not anywhere I have been. And then we want to improve the quality of psychiatric care and primary care. All right, I love primary care providers. I work in primary care. You look at the data, most behavioral health psychiatric care that's provided in primary care is considered below adequate. There's data to show this. You just don't have the support and training, and you don't have the time or the resources to provide kind of the quality of care that we know that should be provided. So we need to be better in primary care at psychiatric med management. So how do we do this? We do consultations with our psychiatrists via telemed and phone. And this is probably the most common way. Our director of psychiatry has a cell phone. We have our integrated psychiatrists with their cell phones and telemed, and we will call them. It is a 3 to 4 minute conversation. I've got a 44-year-old Caucasian female here. She has a history of treatment-resistant depression. She was on Paxil for however many years. Now she's saying she can't sleep. The precipitating factor was X, Y, and Z. She also has diabetes. She's experienced increased weight gain. We think it's because of Paxil. And this is what we want to target. And then they'll say, okay, try this. Okay, and they can see the chart. They can see the labs. And if it is as simple as try this, that's what we do. Sometimes they will say, I'm going to see them. So I put them in my schedule for this week. They will typically allocate 2 to 3 hours. We've never had to allocate more than 3 hours a week to primary care. They will see that person for a one-time consult, or 1, 2, 3 times, 4 times, just to stabilize them, and then they get reabsorbed in primary care. Just like that model I talked to you about before. Okay? They will also triage to specialty mental health. We just did this data analysis. So 3 or 4 years ago, we looked at the specialty. We said, okay, when we have consulting psychiatrists, what percentage of people eventually need specialty psychiatrists anyway? And it was less than 4%. And in all the sites. But we were afraid nobody would believe us. So when we were doing trainings and we were sharing data with people, we said less than 10%. So we just redid the data a few months ago. And in fact, I need to put this in a graph. We redid the data for our clinics, and it is, again, less than 4%. Less than 4%. If they see a BHC, and they are on psych med, so these are people who were started on a psych med, who needed psych med, not just the general population. Those primary care patients who saw a BHC and needed a psych med, of those people who needed specialty psychiatry, less than 4%. We were able to manage over 95% in primary care with psychiatric consultation and support. The way we do it is having that one-on-one consultation with the psychiatrist. Most of the time, they never see the patient. Sometimes they do. They'll stabilize, and once the patient is stable, they come back. The BHC is a really critical part of it because we're monitoring the patient, and we are the eyes and ears of the psychiatrist. We can say, they'll say, what's going on? How are you conceptualizing this? We have the treatment team, so our psychiatrists will beam into treatment team, and they'll bring up cases, and they'll say, what should we do? You tried them on this, this, and this. What should we do? And they have very good feedback. We also do, we call them stump the chumps, mostly because our director of psychiatry, really close friend of mine, to 2 clinics. We're going to our Inglewood clinic, which is near where you grew up, Ben, near Chattanooga and Mid County. Then we're going to go to our Clinton, which is a new clinic in Clinton, which is near Oak Ridge, where like they make nuclear bombs. And nuclear, you go there and you see this is the exit to the National Nuclear Facility, and it really, really makes you like not want to eat or drink or breathe the air. And we just say, what questions do you have? And then there's like this one, 30-second silence, and someone will say, well, we have a lot of people, we have a lot of people complain about sleep. What do you think about this Lunesta? Because everybody wants the butterfly pill. And then it's like, they can't stop. Then it all opens, the gates opens. And what's fascinating is people have been doing some of the same things that they were taught way back in residency training, and it may be like 15, 20 years ago. So they're still giving Elavil for sleep because that's what they were told. That's how they train. They're still giving certain meds. They'll ask, why is Valium so bad? Why do you guys get so mad when we do refer this and this? Well, what is this new drug? What is Prestige? Is it really different from Effexor or Cymbalta? What is this? So that is so important. And you'll see them before we had electronic health records, they would bring in their, folders, their charts. And you could always tell because some charts had like volumes, volume 1, volume 2, volume 3. So we're doing that, and it's pure Q&A. They'll ask me, how do I talk to this person about this? And it's fascinating. I had a doctor, this is really interesting. Finally, he said, how can I say no in a nice way to a patient who is really pushing for opiates? Because I get into it with them. Can you talk to me about how I talk with them and what I do? Because this is so different from, I've been trained to sort of like be very positive with the patient, and they get really mad at me. Okay, what's my time? We are at time.
You guys are fine.
I told them, I said, I'll be done in 45 minutes. Sorry. Is it okay? Really? For those of you, when I was first learning, when I was first training, people say never ever get between people and food. And I feel like I've broken the cardinal rule. So if you're hungry, you don't want to listen to me. I promise you, I will not be offended if you go get food. Please, food is so important. Okay, let's talk about implementation. Basically, I know it's really hard, competing priorities, oh my goodness. We all have 150 million things, right, we need to be doing. It's not just integration, it's PCMH, it's NC2A, Joint Commission, all this QA, there are 40 million other things that we have to do. I know that. We know that. That is a major challenge. And then there's the everyday, tyranny of the urgent, right? The tyranny of the urgent. What about this phone call? This person quit. This person wants this time off. It is very challenging. The logistical barriers, the financing barriers, workforce issues, it requires a paradigm shift. I know all of it. There isn't a single challenge that we have not faced and don't continue to face. We face it too. So what we found is, first of all, start with your mission and say what's really important to you, because this is what we did. Okay, you want to increase access, we want to eliminate disparities, ensure a patient-centered culture, improve the health of our population, and reduce healthcare costs. That's our priority. So when you talk about the tyranny of the urgent, we would get stuff come at us and we would say, is it consistent? Is this something that's going to help promote our value system or not? Otherwise, you just get lost. Okay, you will be subsumed in the black hole of the 40 million things that need to be done. And tomorrow will be 45 million. Trust me, it multiplies exponentially. So what you have to do is build the right team. Build an interprofessional team. The people will make this. You have to get the right people on the bus. You have to get mission-minded, people who are committed to excellence, good communicators, they're flexible, they value. Every single one of us have been part of a project where all you needed was that one person who sunk the entire ship, right? You know who they are. You've got to get the right people. And so that means you have to get the wrong person off the bus. Right? We have this person. Not going to happen. Change is going to be part of it. So these are the people, I will tell you right now, these are the people you cannot have. They want a solo practice. We've had people come in, which is amazing. Again, people don't read our website where we say we want people who want to work with others. I want to, it's my clinic, I want to run the show, my team, my flow, my, me. It's not going to work. I have therapists who say I'd like to keep my door closed, and it's very important for me to have a window. And I prefer this wattage bulb because I like a certain not going to work. I'm sure they'll be very successful somewhere else. These are our lessons learned. Please know we have to define the mission, what you want the model to look like for every single person. Be on the same page. Remember, this is a garbage can term. The integrated care, it could mean 10 different things to 10 different people. So what does it look like? What do you want it to look like in your system? Make sure you have your administrative frontline people in this process, because that's where it can fall apart, and it's the least paid, least trained person, the highest turnover staff position that we're asking to do a lot differently, and this is where it can fall apart, the scheduling piece. They are the front lines. Make sure you have that engagement. Make sure you invest in training. I'm just telling you, these are big battle scars for us. Whenever we've not invested in training, I pay for it times 3. Whatever you think, no, that's enough, it's not enough. Whatever you think, it's not enough. Invest in training and building the right team. That's kind of the take home I can send to you. We've made that mistake before, and boy, it's like you can pay for it exponentially. Financing this, you're going to be talking about this more in the breakout session. So all the clinicians who are not coming to my clinical competency session can go to the main session. Basically, these are the different ways that you can pay for it. Fee for service, you already know what I think about that. Case rate capitation, I think, and I suspect, that the way healthcare is funded in the future will be something that we don't even have in place right now. It will be different. But in general, we are going for global payment. This fee for service, nitpicky coding, here, this code gets paid for, this code doesn't. You can't have 2 people on the same day. It's just creating tremendous barriers, and it's just not going to help achieve the triple pain goal. So whatever you can do, and I love what you guys are doing with the CCOs, organize and really, really advocate for global payment and flexible payment, not the piecemeal nitpicky stuff. That will just drown you. That will just drown you. So what we did is we just placed a value on integration. We said, all right, what's important to you? Medicaid, payers. This is where we looked and said, where's the healthcare cost going in Tennessee? I don't know if you can see this, but the huge bulk of the cost is going toward inpatient care, specialty care, and ER. That's where it is. Mental health is 5%, mental health inpatient is 5%. But if you look at everything else, that's where the cost is. So we had to show an impact on that. We had to say we will reduce ER utilization, reduce inpatient, reduce ER specialty referrals, and we want to increase primary care utilization, and that's exactly what we did. So we tracked this, and in fact, we just got updated data about 6 months ago from our largest payer, and it is very similar to this. So we want to track it over time, and what you can see is, in general, our cost is 2/3 of cost of any other patient. A Cherokee patient costs the largest payer in Tennessee only 78% of what any other patient costs, and they compared us to every other provider in the state. So we are going to them saying, now we're going to share some of these cost savings, okay? Because our model, we're doing it in a certain way that's saving you money. Our ER visits are only 1/3, right? Because they can come see us, we're going to see you same day versus going to the ER. This is our psychiatric admissions. We've been tracking this for years. This is comparing us to every other CMHC in the state and comparing it to the average in our region. So if you look, our average is 18% versus everybody tremendous cost savings. These are just some reflections I'm going to wrap up with. I'll just let you look at them. The thing I'm just going to focus on, number one, patients lead the way. They will tell you, please ask them, look and see what their need is. And I'm going to focus on the second now. Never let the manifest demand obscure the unpresented need. There is so much need in your communities. I know we are all overwhelmed, but we have a responsibility to go out and to outreach and understand that the people who show up at our door need our care, but for every one of them, there are 100 people who are not showing up. Why? Why not? We need to bring them in, because that's the only way we're going to help our communities be healthier, be higher functioning, and really be part of the entire quality of life for our nation that we need to accomplish with the AAA. So thank you. Sorry. I choose to blame Ben. Ben again. I started this off blaming Ben for the IT stuff. Now I blame Ben for not coming in and setting my time.
Thank you so much. Wow, thank you. Lunch is out the door?
Lunch is out the door. We can